center, and that is where this theme will be. So whenever you guys say, we can start.
I'm just putting it on YouTube now, so just give me a second to get that on there. Because we're also broadcasting on YouTube. Okay, we'll start in just a second. Yeah, we have almost 20,000 followers in the YouTube. Dr. Gaballo, welcome.
Thank you so much, Dr. Bennett. How are you?
Good, how you doing? This is Dr. Sharma.
Hello, everyone.
And I think you met Sarath before.
And Dr. Surat, yes, I think Dr. Surat, I met him before.
Yes.
In this platform, of course.
Yes, we have met.
Okay, Sarath, we're ready to start?
Sure.
Okay, let's go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning in Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. Today we have the honor of having Sri Lanka Neurosurgical Grand Rounds. Sarath will explain what he's going to talk about and how it's going to be structured. He's done many webcasts and he's very active on the internet. So, and he'll essentially run this show. Okay, Sarath, welcome. Thank you.
Thank you, John. Thank you for giving the opportunity. Good morning, good evening, good afternoon, wherever you are. So welcome back to another episode of Sri Lanka Neurosurgery Grand Rounds. So today the topic is on a very important and a common aspect that we talk about as neurosurgeons and spine surgeons, even orthopedic surgeons, complications in spine surgery. And today I have the honor of having a very experienced spine surgeon, Indian spine surgeon, Dr. Ayush Sharma. So we welcome Dr. Ayush Sharma very warmly. So as usual, I will be giving an outline of what are we going to talk about today, and then we are going for a case-based discussion as usual. So let me share my screen first. And I hope I am visible and audible.
Yes, perfect.
Right. So today we are going to talk about complications in spine surgery and the importance of decision making at the very beginning to prevent complications and to achieve a good outcome. So from a theoretical point of view, so I will be mainly focusing only about the cervical spine surgery complications. But when we talk about when we come to the cases, we'll talk about, generally with cervical and lumbar spinal cases as well. So talking about complications, it's very common. And if you operate, we know complications will occur. It's unstoppable. So one should not fear about complications and should be able to manage them when it occurs. So as spine surgeons, neurosurgeons, and orthopedic surgeons, so we should be ready to manage our complications if we are operating them. So we have to anticipate. We should always try to prevent the complications. And there is no universally adopted definition, but this definition given by Dindo and Clavin is accepted, although it is not universally adopted. So in general, the complication rate in spinal surgery ranges between 7 and 20%. So, and as we all know, generally the higher complication rate seen in posterior surgery than in anterior approach, and especially if we are doing multi-level surgeries, redo surgeries, and as the operative time increases for more than 5 hours, and for patients, old age patients, elderly patients, and obese patients with high BMI and ASA score. So all these scenarios have a much higher complication rates. So how to prevent complications? Selection is very important. Selection is key, as well as decision making. And always one should try to correlate the patient's history and physical examination, imaging with his the clinical scenario, and should make a decision. So as a surgeon, you should be able to determine the surgical goals early and to achieve an optimal outcome. So optimization of the patient is very important, and also patient should be educated regarding the complications. So we should get an informed written consent. And also, when you are selecting an approach, you have to think about the type of pathology, the location of the pathology, the alignment of the spine, number of levels that you're going to operate or to fix. So all these are important. So the importance of correct decision making is mandatory. So these are some of the complications, as we all know. I'm not going into the depths of the theoretical aspect. Infection, very most common. Dysphagia, hoarseness of voice due to recurrent palsy, and damage to trachea, pharynx, esophagus, the surrounding structures, especially in the anterior surgery, damage to blood vessels like vertebral artery, carotid artery. You can get dural tears and CSF leaks, neurologic complications, which can be disastrous, spinal cord injury or nerve root injury, and also not uncommon graft-related complications such as dislodgement. We had seen cage subsidence in ACDF, loosening of screws, non-union, pseudoarthrosis, etc., etc. And also, we need to remember wrong level surgery, excessive blood loss, sometimes retained drains, and also donor side complications when we obtain the grafts, and also cardiac and pulmonary complications, and finally death, although the percentages are low. So how are we going to prevent them? So prevention should start from the very beginning, preoperatively, and it should continue preoperatively, intraoperatively, as well as postoperatively. So when you talk about prevention, so it should start, as I said, from the preoperative point of view as well. So during anesthesia, how are you going to prevent the complications? So anticipation is important, as I said. Prevention is the key. So during anesthesia, we should try to maintain the mean arterial pressure, especially in myelopathic patients. So we know we use neuromonitoring, MEPs and SSCPs, especially in myelopathic patients. So we know about fiber optic intubation, awake intubation, and also we should not excessively manipulate the cervical spine, especially in unstable cervical spines, and especially in degenerative cases as well as trauma cases. So we should not excessively apply traction when you tape the chin, as in ACDF, and we should not excessively pull the shoulders to prevent brachial plexus injuries in cervical spine surgery. And at the same time, we should anticipate postoperative airway obstruction, which can cause serious complications. So few words about the postoperative airway complications. Hematomas can occur, so meticulous hemostasis is mandatory. Sometimes graft dislodgement can cause compression of the trachea and the esophagus, so causing laryngeal edema. Especially this is common. This is much common in upper cervical procedures than lower cervical procedures, and also can occur in obese patients commonly, multi-level cases, multi-level procedures, and redo cases. And what about the positioning? How we prevent complications in positioning, which is extremely important from a surgeon point of view to prevent iatrogenic injury to an unstable spine. Especially we know in ossifixation, if your positioning is incorrect, so it can affect the patient lifelong. with the range of motion. So as a routine, we need to always check the alignment of the positioning. And we used Mayfield head holder in most of the situations. So make sure the occiput is above the thoracic cage. These are very, basic few points. So talking about the complications in cervical spine surgery, so dysphagia is one of the common complications that we identify. So it's the most common complication in anterior procedures such as scopectomies. And as we know, the severity decreases over time, but it can persist up to 3 months. So how are we going to prevent it? So what we usually do is we intermittently release the retraction. It has to be gentle retraction, and we need to intermittently release the retraction, especially in anterior cervical procedures. And some use local steroid application where they use methylprednisolone soaked gel form. But in my practice, I have not used this commonly. But there are papers which brings about the efficacy of this as well. So this is another way. When I do 4-level ACDF, more than 3-level ACDF, rather than the transverse incision, I use a longitudinal incision in especially all the elderly people, because this can give an bit of unsightly scar in young patients. So I prefer not to use a longitudinal incision in young patients. Then this is again a common one: recurrent laryngeal nerve injury, recurrent laryngeal nerve damage causing hoarseness and sometimes dysphonia. And if you damage the superior laryngeal nerve, there is a risk of aspiration as well. And it is associated with dysphagia as well, usually transient, more common in high anterior approaches like C1, C2, C3. So how are we going to prevent it? Medicular soft tissue dissection, minimal or intermittent retraction, as I said, that is again to prevent dysphagia as well. And what we do usually is intermittent deflation of the endotracheal cuff and to maintain it around 20 millimeters. And also, if the symptoms are persistent, we always should get the, we should not bother to get the, we should not hesitate to get the opinion from the ENT surgeon as well. So some people say when you approach from the left side, the incidence of recurrent laryngeal nerve palsy is less, but that is not validated yet. So mostly what we can at the moment say is no association between the right or the left side. And also, as we know, there's high chance in redo surgery during the anterior approaches. Then esophageal injury, which can be a devastating injury, which is rare, fortunately, with an incidence of 0.3%. So mostly it is due to the trauma from the birth, especially when you do a corpectomy. And also can be due to damage from the retractors or instruments, and rarely could be due to a dislodged graft. Again, so how are we going to prevent it? So we need to protect the esophagus with the retractors, and probably if we can use blunt retractors, but some people use these serrated retractors because it will stuck on the longus colli muscle. So depending on the surgeon's preference. And also, we insert the NG tube. We routinely insert the NG tubes for anterior cervical procedures, except for a single level ACDF, with the duration is very short. And if occurs, early detection is the key. It is the most important thing, because if it goes unnoticed, it could be a devastating injury with a high mortality. So we need to suspect in any infection of the anterior cervical spine procedure. If you get an abscess, so we need to suspect esophageal injury. And some surgeons do what is called hydrogen peroxide test intraoperatively to identify esophageal injuries. So if occurs, so these are the options: direct repair, or we could reconstruct with the pedicle muscle flap, especially the sternocleidomastoid. And we need to rest the esophagus with NG feeding or PEG tube and antibiotics. All right. So a few words about the neurological injuries as well. Spinal cord injury with the incidence of 1%. It's rare. So again, it's a devastating situation. So a proper identification and visualization of anatomy as well as pathology is very, very important to prevent spinal cord injury and to injury to the nerve roots. So meticulous hemostasis is important, patience is important, and also use of appropriate surgical tools is important. So damage to the neural structures can occur especially in OPLL surgery and deformity cases and in patients with severe myelopathy. So spinal cord monitoring, that's what we are doing. And also, as I said earlier, maintaining the mean arterial pressure to prevent intraoperative hypotension. So we talk about this cautious intubation, and also if neurological damage occurs, we need to slow down, we need to be patient, need to identify, need to use whatever the resources, get the C-arm, check the levels, check the anatomy, check the pathology. So everything is important. Another complication is inadequate decompression, giving a suboptimal outcome to your patient. So that's why, as we said, preoperative planning is important. Identification of the anatomy is important. Localization of pathology is important, and correlation with imaging is important. Right. So these are few examples of inadequate decompression. You can see this is one of my cases. Early cases in early days, corpectomy. You can see the corpectomy on the right side is not very adequate. Again, here also you could see. I mean, it's not bad, but would have been much better if more towards the right side decompression was achieved. Again, you could see this is a 4-level ACDF, but we don't have adequate length anterior cervical plates, so only a partially a plating was achievable. Again, you could see fibular graft and anterior cervical plating slightly angled, not in the midline. I mean, these are not, not big things. Like this can happen to anyone, but not optimum, right? So dural tears and CSF leaks, we all know. Again, identification is important. It's common in OPLL surgery and redo surgeries. So as we understand nowadays, we do the floating techniques in OPLL to prevent damage to the dura and to damage to the spinal cord. And if it occurs in anterior cervical approaches, direct repair if feasible if feasible, but we know it is technically demanding in anterior surgery. So in that cases, we usually go for a lumbar drain. But if it occurs in posterior surgery, we can use tissue glue, or we can suture with a pedigree of muscle, which usually settles with time without any further complication. C5 nerve palsy, we all know, very frustrating complication. However much you do, however much a perfect surgery you do, sometimes we cannot prevent this complication, which is very, very frustrating as a surgeon. With this overall incidence of 6%. And as we know, it's more common in the posterior approaches and also in OPLL surgery. What is the reason? The C5 nerve root has a unique anatomy. It is the shortest root with an most obtuse angle. So the cause is due to tension, or some say it is to reperfusion. So what's the treatment? Some use steroids, but we all use physiotherapy postoperatively. And some say to prevent it, a prophylactic foraminotomy has a place, but I don't know. Some people say if you do a foraminotomy, sometimes the incidence can increase. But I have not much experience with this one. And also people say the width of the laminectomy. So if the width of your laminectomy is more, there's a high chance of you getting a C5 nerve palsy. So some people say to leave the C5 lamina, and obviously we need to avoid excessive traction on the shoulders, right? Another complication, vertebral artery injury, which is rare, fortunately, with incidence of 0.1%, but it's a dreadful complication if occurs. And it's more common in corpectomies and also in high cervical, upper cervical spine posterior instrumentation, C1, C2, and also we have seen in cervical pedicle screw fixation. So these are the common causes. If your corpectomy is excessively wide, if it is more than 17 millimeters, there is a chance that you damage the vertebral artery when you drill, when you burr the lateral aspect of the vertebral bodies. And especially if talking about the vertebral artery anomalies, if it is unrecognized preoperatively, or if there are tortuosities, there's a chance that you damage the vertebral artery. And also, if you dissect beneath the longus colli muscle excessively, there's a chance that you damage the vertebral artery. So the prevention, as we said, limit the width of the corpectomy to 17 millimeters maximum, identify the important anatomical points, identify the uncus, and also pre-op imaging, as we said, to identify the anomalies of the vertebral artery. Use a diamond burr, which is a bit safer than the Rosen burr, and laminoforaminotomy to identify the pedicle if it is difficult in C2 fixation, C2 or C7 pedicle screw fixation, and careful dissection at the superior aspect of the C1 ring when you do a C1 fixation, which is not more than 8 millimeter from the midline. So management, we know, tamponade with hemostatic agents, if possible, direct repair, and to be on the safe side, we do endovascular procedures post-operatively. And hardware-related complications, not uncommon again. So I have seen all these complications, and it occurred to me: graft migration, cage subsidence, vertebral body fractures, graft fractures, pistoning effects, especially in multiple corpectomies. If you perform more than 2 corpectomies, it occurs usually under supraphysiologic loads. Pseudoarthrosis, not uncommon, and hardware failure. So how are we going to avoid these hardware-related complications? There are lots of things we could do. Preserve much end plate as possible. Avoid over-distraction. Over-distraction is bad. Remove distraction before you apply the anterior plate, and consider posterior fixation. Also, if you are doing more than 2-level corpectomies. So more than 2-level corpectomies are nowadays much less common, but if you want to do it, you need to strengthen it with the posterior fixation. So this is one of my cases. You can see after some time the lower end. This is a 3-level corpectomy. I haven't done posterior fixation because this patient could not afford it. You can see after 1 year, the graft, the lower end of the plate is coming out. Again, here you can see OC fixation. There is the screws are coming out, and there's a fracture in the screw as well, in the occipital screw. This is not one of my cases. So I have never I had only one case of graft dislodgement in ACDF up to now. This is done by another surgeon at a different center. So both the grafts were coming out. So when I went back to operate, I saw that only the half of the disc was removed, and they have just inserted the cage. So there was no wonder the cage was coming out, jutting out. So this is one of my cases. So this is this is unfortunate. I'm not a big fan of 4-level ACDF, but I had no option when I don't have facilities to fix posteriorly. So again, a cage is coming out, so we don't have proper size cages nowadays, and there is no anterior plating as well. So this is unfortunate, because I always I feel it's always safe to apply an anterior cervical plate if more than 3 levels are operated in ACDF. Right, pseudoarthrosis, again, so we all have encountered in our life, which is defined as absence of continuous bridging. So there are various definitions, and as the number of levels increase, 4% risk per level increases. Graft material, allograft versus autograft, we all know. So I'm a big believer in autograft. So I think the best graft is the autograft. Some people use iliac crest, but I prefer to use fibula, and I see it's an excellent graft material. And these are the other causes: poor bone quality, comorbidities, and it's smoking, etc. So post-op wound infections, the commonest. So we all know, we all have managed this, we all have encountered. So these are the risk factors we all know. So it is common in posterior approaches than anterior approaches. Antibiotics, some use local vancomycin. So this is the most important, I think: meticulous soft tissue handling and meticulous hemostasis to prevent hematoma. There's a high chance of infection if you traumatize the soft tissues. Right. So for the moment, I'm having few of the cases. Two of the cases I want to get the opinion of our spine surgeon, Dr. Sharma. So let's move to cases of Dr. Sharma. So it's over to you, Dr. Sharma.
Thank you, Surat. It's always a pleasure, to be here. So, the idea is to, show a few of the cases, and then, we can talk about it, how to go. So, mostly it's a case-based learning, which I believe in. Your experience, as per your cases, they are the best judge, and they're the best teacher. So I always say this to my fellows and my colleagues: if you say you have no complications, then either you are lying or you are not operating at all. So if you are operating, you will bound to have complication. And let me show you some of mine. So let's start with the first case. So this is a 52-year male. He presented with significant back pain since roughly 1.5 months. He was operated 15 years back for the stiff, and he was almost absolutely fine. And now he came to us with back pain. With back pain is significant, he cannot get out of bed. He's almost like he says, I lie on the bed the whole day. What do you think, Surat? What is happening here?
Is it one of your cases? So this has been done somewhere else?
This has been done somewhere else, but this is the time. This is the time he presented to me with this X-ray.
Right. So it's as we discussed, it's hardware failure. It's a posterior dislodgement of the tail-lift cage, and he's presenting with significant back pain. Is it?
Yeah. Only back pain, no radiculopathy, no nothing, no neurological. Significant back pain, which has almost made him like bedbound.
Right. So how many years after?
15 years after the
15
first.
years. So obviously there is no fusion. You can see it.
Yeah. So that is what we also thought, but we felt something is not fitting into it, because if you didn't had a fusion for 15 years, it should have came out much early. So we went ahead and got a CT scan done. If you can see the image, the CT scan shows a complete bony fusion at this level, but something funny happening at the level below. Can you see that, Shurat? So if you see the CT, there's a complete bony fusion, but down below there is something funny happening. So we went ahead and got a MRI with contrast, and this unfortunately is not a problem. There's a discitis in level below, so that explains things. So the idea to present this case is, don't go by what glares to your eye, but see the whole picture. Make sure you get it right. So this is yeah, please.
Excuse me, Ayush. Do you mind if Vladimir and Dr. Gabullo comment, or anyone, the panelists during do you mind if they comment?
No problem.
Okay.
Anyone is most welcome. I don't mind at all. They are most welcome to come in. They are most welcome to give their comments, and they're most welcome to give their thought process as well.
Okay, onward.
Okay. So basically, at this time, we know that there is a discitis, and there are many ways to treat a discitis. But this patient, he was on almost like a bedridden for almost 45 days. So there's option: you can conserve them, give them empirical, or go and do a biopsy. But he was like, no, I had enough. You should do something about it. So this is what we did. These screws were so solid they won't come out. They are almost bony fused. Okay. So I went ahead, I did the fusion, and we did bone graft at for L5S1. Now he was absolutely fine with his back pain, but when he walked, he started complaining of left-sided radiculopathy, only on the left side, a radiculopathy which is going. Any comments, Surat, there?
Yeah, what about that screw?
Yeah, exactly. So so this screw, of course, looks funny, but even there is a cage migration. So I was not sure if maybe because I have removed the rod, maybe that cage is doing something funny. So but I have a high degree of suspicion that it was the screw. We got a CT scan and screw looks bit anterior, this one, and we, although you can see solid bone guard which we have put. So what I did is, just to be sure, we injected through the transforaminal route 2 ml of lignocaine, not the steroid, because if there's infection, you don't want to flare it up. Just the lignocaine to test, because this screw, as you know, will hit the L5 root, because that is where the L5 exists. So this is your the transforaminal select L5 root block without a steroid, just a lignocaine. And patient had, and you can see this is how you can see the root block which is going like this, and this is where mostly he was getting hit. And patient had an instant relief by 70 to 80%, and that is time we sort of made sure that this is the culprit. So this is what you do: you change the direction of the screw, and this is where it is. So we just medially directed the screw. So if you follow the L5 nerve root, it goes like this here, then this, and here. So if you put a screw, straight screw, there is a good chance, especially in S1, that you might hit one of the L5 nerve root. And if you look at the literature, there is a decent number of publication. And as Surat rightly pointed out, this was a misplaced screw. And the point is, you don't wait for it. You don't see maybe something happening. You go about it. You investigate the patient. You find out the cause, and you deal with it. And that is the message for this case. Any comments, Surat?
Yeah, this has happened to me twice, especially in again L5S1 with a pass defect. So that patient also presented with a foot drop. So I had to go and revise it both the cases. Now imagine if you can see in the CT that your screw is misplaced slightly. And there is a potential. I'm not talking about this case. So imagine. So there is the patient post-operatively doesn't get any pain, but there is a chance or a potential that he might get as the time progresses, that there will be a chance that the patient get again a radiculopathy because the screw is close to the nerve root. So in that cases, what will you do? You are going to reverse it, you are going to redo it, or you wait?
To hit it bullseye, there's maybe, if you see this, unfortunately we really hit that one bullseye. But even a slightly medial lateral screw won't cause a problem. So there's no point of revising without a symptom. You just tell them that, okay, if something happens, you should come to me immediately, and that is where it is. And if you see this patient, they don't get this radiculopathy on post-op day 1. It is when they walk, there is a micro movement. On day 2 and day 3, that is where they start complaining of this radiculopathy. So so I don't think you should go and revise until unless intraoperatively you have done something. But you wait for it, and if they hear a symptom, you go for it. That is what I found. But if you identify it intraoperatively that your screw is lateral and is likely to hit, you better do it before you close the patient.
Thank you.
So let's move to the next question. She is a 26-year female. She complains of backache and fever. She has, and you can see a big pus out here. She underwent a biopsy in March 2019, and nothing came out. In India, tuberculosis is the most common thing. So she was put on antitubercular drug for 18 months. There was no relief. Patient again underwent a second biopsy, and again it was unconclusive. And this is time she came to me. She has been given antibiotics, she has been given antifungal, she has been analgesic, she has been given physiotherapy, she has been on on psychiatric medication. And finally, she comes to us, and this is what we see: a lot of levels involved, a lot of things happening. 2 to 3 times biopsy has been attempted, CT guided biopsy, CMA guided biopsy, but nothing conclusive. What will you do for this case, Surat? It's like a complication in itself. There's no diagnosis in spite of a lot of interventions happening.
Yeah, it's a
Failing to diagnose.
complicated case.
So we felt and it seems pretty bad if you see a lot of levels involved. There's a there's a discitis or something funny happening, and even the bony destruction has started. And you look at her. So this is how she's getting unbalanced, completely off chart. And if you want to go with your screws and cages, it is like you are likely to burn the only bridge you have, and because you don't know what is causing the problem. So I was not in a favor of going full in and putting all my cages and all my screws, because it's something, if I don't get anything out of the biopsy, I'm in for a soup, because the failure, if you fail with your implants, you'll fail in a big way. So that is where we went out of the box, and we went is, and this is just not from this case, but another. So we went with a endoscopic biopsy. So what it allows you have a direct visualization of the pathology. You can take as much sample as you want. You can really target the pathology. And what we do is, after taking the sample, we give a antibiotic box, like whatever the broad spectrum antibiotic. So this is how it looks like. You see, you can really go in there until under complete vision. You do your biopsy. You can even do it in local, and you take the pathology with a vision. And this is what happened. There was a very low detection, but we got her as MDR, which is multi-drug resistant tuberculosis. So that's why she has failed all the treatment and nothing was working. And that is the beauty of doing this. And fortunately, we have started her on the reserve line drug, which is not the primary line of treatment. And she has been doing fine. And the idea is to, of course, fuse her on a later date, because I just wanted some control of her infection for 6 to 8 weeks, and then we have planned for a second stage fusion surgery. So much so that now we have 18 to 20 interesting cases, and this one of our paper of endoscopy spine solution in spondylodiscitis is being accepted for presentation at Global Spine Congress. So it is a interesting case series of something like that. And now for all our discitis, endoscopic discectomy lavage is the primary mode of treatment, and we have a very, very good success rate with this. So you can do it with a 8 millimeter incision, and I can just tell you, we have normally if you do biopsy, either a percutaneous or transpertubular, your biopsy yield is roughly between 30 to 50%. In our cases, we have 85% biopsy yield, because you can get as much biopsy as possible. You can really target the pathology based on CM. So this is one of the paper I will be presenting in Global Spine Congress, just in case you happen to be here. So this was my second case. Any comments from you, sir?
Yeah, it's great. And may I ask you a question? So, discitis cases. So you said you put bone grafts after fixation with the pedicle screws. So have you ever used the allografts as well? And what is your experience with that?
So normally, what I do is, when I'm doing this, I remove the facet. Normally, if you see most of these cases, there's a disc which is involved. Your bone is almost spared until unless it's something very, very significant. So because I go with tubes, so I dock on facet. So I get a lot of autograft in these cases. So if you see the previous case, if you see the CT scan, look at the graft which are packed in completely from one end to other. So one of the reason is, one of the reason I prefer bone graft here, not a cage, is cage. There is a slight chance that there is a high incidence of cage migration. in these cases. I also used cages in few cases where I thought it was very important to put them, but my primary choice of in these cases remains autograph. That is where I.
Thank you.
So moving on to the next thing, and this is, I just wanted to bring in because, we are talking about discitis, a complication. So we have a big series on dual tear, and, I just wanted to share it. It's not a case, but it's a complete study which we did in our department. So basically, this was during from 2017 to I think 2020 that we looked at all our cases of dual tear, whether we operated them on open or through minimal invasive surgery. And we had 420 cases in the series, a big number, and we divided them into two groups where we did a open or MIS surgery, and we had 156 patient in MIS and 264 patient in the open group. And we to our surprise, we thought our dual tear number will be pretty less, but we got the incidence of dual tear was 12%. It was equally divided between male and female. There was no difference, but this was very interesting. If you see, for TILIF or instrumentation, whether we did open or tubes, it doesn't matter. But in case of discectomy, the MIS, the dual tear, was significantly low. Again, in revision surgery, the dual tear is as high as 40%. Maybe we are not that good in revision surgery with open, but in case of MIS, it was as low as 13%. So if you see the data on this, in our case, it was almost 6.4% for MIS group, and it was like 14%, 15% for open group, which is a significant reduction in dual tear if you do it through a tubular approach. And if you see, the literature is varied, from 0.3 to 35%, but average around 10%. And if you look at the literature, very, very interestingly, if you see a prospective study, the incidence of dual tear is twice that of a retrospective study. So if you see the retrospective study, the incidence of dual tear is around 4 to 5%. But any prospective study, the incidence of dual tear is almost 10 to 12%, and that is even what our data shows. So this is what we believe. What happens if you're doing open surgery? You remove all the posterior element. So if you're dual tear, you have a lot of dead space for the CSF to flow. But this is one of our cases where we had a dual tear in a tubular decompression. See, once you remove the tubes, the muscle simply falls back. So even if you have a dual tear, it's a contained dual tear, and this is a 1 year follow-up, and so everything sort of heals back. And that is what we believe, and that if you're doing it MIS surgery, it sort of helps you prevent a complication that every one of us has. And we published this paper. This is now a part of literature in 2022 November in Asian Spine Journal. But because we are talking about the complication, I thought it is a good literature, and because we are the author for this paper, to bring it in. And I have documented 52 dual tears, so you can imagine that it does happen. But we believe that if you approach it through a MIS, the chances of dual tear and the complication related to dual tear is significantly less. Any comments on this, Surat?
Yeah, actually, I don't have much experience in minimally invasive, so I think it's a very good study to further continue. So
much so that the next serious study which we are doing this was through a tubular approach. Now we have gone for endoscopy, so we'll compare our data with endoscopy, and we'll come up with a new group, and which will say what is the incidence if you go endoscopy, because as we have progressed from open to tubes to endoscopy, I think we are in a very good position to comment on each and every technique. I think the dual tear is bound to happen if you're operating, and that is what it shows. The only thing it happens is because we believe, and that is what we try to show in the study, because even if you have a dual tear in MIS, what happens is if you come out, the muscle layer just simply falls back. But in case of open, because you have dissected all your muscle layer, you have a lot of dead space, and that accumulation is because dural leak is not a problem. It is the healing which is a problem. So if your external layers are healed because the fascia and everything has fallen back, that saves you sometime when it comes to DVT.
Yes, completely
So
agree with that.
yeah. This is again one of my cases. She is a 55-year female. She presented with back pain. You can see she has a degenerative scoli, and but when we examined her, and this there's a multi-level involvement, and you can see significant lumbar canal stenosis at least 3 levels. But when we examined her, we found that one of her grip strength was very weak. So her power on the left side was 2 by 5, and that is when we got her screening done. And you can see something here happening here, very funny. And there's a ossified ligamentum flavor, and on the one side, and that is the culprit here. So these are very very difficult cases, as you know, because and so this is where we use a ultrasonic scalpel, because if you see this video, this interpret, you can see this flavum is the calcification is simply going inside the dura. There's no way you can do it safely. So what we did is we went all around it, and we simply we used the ultrasonic scalpel, and like a floating technique, we let the ossified ligamentum flavum be there and shaved it off all around. So fortunately we have this tool which allows you to do that, and this is just the demonstration of it. So this is not the complication, but this is the case. So you just let it float all around, let it be there, and it keeps floating, and you decompress your cord. Because if you try to remove it, it will lead to a significant damage. And you can see this patch of island we have left behind, but we have completely decompressed the cord. And this is the post-operative CT scan, you can see. And of course we fixed it because we thought we had to go pretty lateral. This is a post-op MRI, and you can see the post-op CT scan, and you can see that we have done a decent job. And this is the 3 months follow-up, where you can see that the ossified ligamentum flavum is completely gone. But this is the time she came to us and she said, "What about my lumbar problem? Because I came to you for lumbar problem, not for the cervical one." And we decided to do a second stage 3-level OLIF. OLIF, if you are aware, you go through the abdominal approach and you put your cages. The reason I prefer OLIF is because there was a degenerative scoli, and in these cases it works very very nicely with us. But unfortunately, this is the cage which is going in the L4-5 level, and this is my tubular system which is going inside. But after putting the cage, as these are expandable tubes, I was trying to take out the tubes, I saw a gush of blood simply coming and popping out from all over. And this is the intraoperative image. You can see this is the left lumbar vein, and this is the anatomy you go through. So this is not normally, you don't see this, but this is because I have expanded the tubes, because I saw something like a full gush of blood. You can see my cage somewhere here, and I'm trying to find a bleeding point, and this is where I am. No bleeding as of now, but as I go and poke the left lumbar vein, you will see within 5 to 10 seconds that there's a big there's a big bleeder there. You can see there. So this is where you have so this is like a it's a pool. Within 10 seconds you have a pool of blood. So we pack the whole thing, and this is, if you do anterior abdominal surgery, there's a vein which goes through from the left lumbar vein. It's called iliolumbar vein, and it is what we had clipped. Unfortunately, it's a valveless vein. So unless you do something about it, it'll keep bleeding, so much so that patient can have a lot of blood loss, and there could be a potential risk. So by this time, fortunately, we realized what is happening. I called my best friend, the vascular surgeon, who was but till that time we could stop the bleeding, and he came, and you can see this vascular clips which he had put, and this is the end of the surgery. This is the vascular, this is the left lumbar vein, and this is through a microscope. See this vein. These are the vascular clips which you have put, and this somewhere here is my cage. So if you play with fire, sometimes you get burned, and that is the problem. Where I love doing OLIF surgery, but sometimes you get these complications, and this is the final result. and then we went ahead and put a screws, and this is what we could achieve. You can still see the vascular clamps which are here due to the bleeding which was happening. And this is the final result of the patient. We see went on to do very well. You can see we have solved the lumbar problem and the cervical problem as well. But and now we have more than 1 year follow up, and maybe 1.5, 2 year follow up. But you can see very, very good solid fusion through the cage. But if you look at the literature on anterior abdominal surgery or OLIF approach, it is vascular complication is around 1%, not much, but if you do it, you're bound to have one. And that's why I always say, for those who do this surgery, remember this: with great power comes great responsibility. So be careful when you are doing this surgery. Any comment from you?
Yeah, actually, a nice case. It's rare, and I don't have much experience in olive, but when you see the outcome, it's a great outcome. Although, and fortunately, patient didn't have any deficits, so it's a good case, nice case.
Yeah, so this will be the last case for me. So she is a 60-year female. She presented with back pain, which was increasing. She is obese. If you see, the BMI is 36, and there's no comorbidity, but she happened to be the relative of the medical director of the hospital, And this is a listhesis L5S1, and this is, you can see the MRI, and this is how she is. She is pretty hefty, and you can see the BMI is off the roof. And we planned her for MIS TILIF because this is what I prefer, minimally invasive TILIF in her case. And this is my trial implant. You can see I used the trial of 12 I felt it is looking very, very good. I'm using an expandable Medtronics cage. So this is just a video to show exactly how this cage works so that you will understand what happened. So basically, you put the cage first. This is how your cage goes in, and then once you put the cage inside, then you expand the cage. So your cage goes in, then you expand the cage. The anterior part of the cage expands, and then you put bone graft. So through the cage. So there's no pre-filled bone graft. So what happens is it allows you to pack a lot of bone graft. Because what happens in most of the cages, if it is pre-packed and you expand, there's hardly any bone graft left. So this is what happens, and this is not this case, but what happened. So in this case, this is where we were. We have put the cage, and then I started applying bone graft to the funnel. When I removed my funnel, if you see this corner, I could not see the cage. The cage has gone missing. I get a C-arm shoot, and this is my cage. What will you do if this happens to you, sir?
Yeah, do nothing.
So first of all, I had a pray to God, okay, because it's a big problem, and remember, this is the relative of the medical director of the hospital, so somehow these things happens to you when you have a VIP patient. So first thing I did is I went ahead and checked my MRI. Okay, so you look at this MRI. Fortunately, it's L5S1, so there's a lot of space anteriorly, and there's no big vessel, nothing. So I had a sigh of relief, but I informed my anesthetic. We called all the blood that was available in the hospital for that blood group, because if something happens, then then what we did is we went from posterior and we put the screw. If you see, there's no screws here. Only the cage has migrated. We compress the whole thing, and we put a second cage on the lateral side, not in the middle, because what I realize is there's a breach in my anterior ligament right in the middle, and that is from where the cage has migrated. So this is how it looks. I have compressed the whole thing, put a cage. You can see the dot, and this is the anterior migrated cage. Then we turned the patient up, went to a retroperitoneal approach, because I do OLIF surgery, so I'm pretty familiar with the anterior approaches. And this is the cage we retrieved, and this is the 8 months follow-up. So if you see, the cage migration is not very uncommon; it is very, very common. So much so, this is a very interesting case where Dr. Nene is again a very known figure in Mumbai. His cage, it not only migrated, it migrated through through the left, abdominal aorta, and went to the heart. And they found the cage in the heart, and they couldn't do anything. It is still there. Patient didn't have any complication. So what we believe is it went to the left pulmonary artery. You can see there. So they have this is from Spine Journal. They published it. So you can have really very grave complications sometime. And what we believe is because we did a expandable cage we are using. So a lot of surgeons, they're familiar with ALL release. So this is what happened. Unfortunately, the ALL, we released the anterior ALL, and that is where my cage got migrated. Fortunately, everything went okay, and but these things happen, and then that is where the experience and all the learning point comes from. So this is where I leave you with: a wise man learns from their mistakes, but a wiser man learns from the mistakes of others. And hopefully, some of my mistakes, you get to learn few of the points. And there we are. And just before I conclude this, there's a small course which we are doing on 4th and 5th of March. It's basically a debut synthesis, a minimal invasive spine course where we are demonstrating a lot of techniques. And so if you're interested, you can go to the website, and you can follow us, and we'll have all the registration, everything. And you maybe even we'll have a online link if you cannot make it to Bombay. Surat, any comment on any of the cases? Anything you want to add to it?
Yeah, it's an excellent presentation, and nice cases, very interesting. So yeah, as you said, we need to learn from the mistakes. So I mean, without the complications, it's boring. So you get complications and you learn from them, and that's how your skills develop, your thought process develops, so you mature day by day. So these are for a neurosurgeon or a spine surgeon, these are not very not something which is unfamiliar. So we all get complications, as you said. If we don't get complications, if you don't get complications, either you're not doing up, either you're not operating, either you're lying, as you said. So it's very inspiring and very interesting. So hopefully you'll be having more and more cases, so we can share them on another day as well. So thank you very much for your time.
Thank you so much. Just two words I would like to say. Whenever you feel you are having complication, I will suggest don't sit on it. Don't be scared of it. Go head on. Do whatever it takes. And you are much wiser being aggressive when you have a complication than sitting on the bench. Don't believe it will resolve on its own. Do everything. If you want to do a CT scan, do a CT scan, do a MRI, do whatever it takes. And that is where I believe and you have the courage to tell the patient that this happened and this is the problem and we're likely to solve it. And you are much better off that way than just staying on a back foot and not doing anything about it. I have showed you a lot of my complications. I have showed you 52 dural tears. I have showed you vascular injury. I have showed you a cage migration. Everything which can happen. So these are some of this is just in the lumbar spine. I didn't bring my cervical spine complications, So but then the thing is that if you see each and every one, whatever happened, we tried to solve it. Fortunately and lucky for me and for my patient, most of them they did fine in spite of having complications. So that is my 2 words on handling a complication. Over to you, Surat.
Yeah, so let's talk about the cervical spine complications next day. And before I wind up, I need to. I'd be grateful if you can give your expert opinion on just 2 cases. So,
sure, please go ahead.
Sure. So this is the first case. So this is as the topic says, the importance of decision making at the very beginning. So this is a lady who 52 years of age, presenting with anal cavity malformation, very symptomatic. In 2014, so she underwent a craniovertebral decompression in 2014, and then presented to me last year with severe neck pain and deformity. So this is the initial MRI, which was done in 2014. before she underwent surgery. So you can see there is descent of the cerebellar tonsil, and there is this the syrinx formation all the way from C2, 3, 4 to C5 level. Again, you can see this in the MRI. So this is the CT she presented with last year. So you have seen, you could see that she has undergone sinovertebral decompression plus laminectomy from C2 to all the way down to C4 level, C4, C5 level. So what is your thought on this one, especially regarding what she had undergone?
So this scary malformation, as you know, is very, there are a lot of thought process and a lot of theories about what should be done and what not should be done. But there is, if, like, of course you need to decompress it, that is there, and you need to give space for it. But I believe what has happened is, if you look at the spine, it has gone into kyphosis because of the way maybe the decompression is done or whatever. So that, I always believe is, the cervical spine, if you cannot, if the moment it goes into kyphosis, because of kyphosis itself, there's already a, like, pressure on your cervical spine. So anytime you believe if you have, if you are likely to put the patient under kyphosis, especially the cervical spine, it's better to instrument it and maintain the lordosis. But if you're doing something and you're doing a simple lami, not a wide lami, and you are not like hampering too much, and you can get away with it, I'm not in favor of instrumenting every case. But if you don't want to see something like this after a laminectomy posterior.
Yeah, I'm sure the neurosurgeon who did this must have thought about the resolution of the syrinx. So the syrinx was all the way down to C5, C4, C5. So that would have been the reason he did the laminectomy all the way down, which I believe which is not very appropriate. So according to the literature nowadays. So that is one incorrect point in decision making. So what are you going to do for these patients?
So now, what is her problem right now? What is happening?
So this is how
It's
she looks
kyphotic.
like.
Yeah.
Yes.
So now there are two ways to do with it. You can go with posterior, but you need to do too much. You need to go with from the scar and everything, which is, I believe, is, if you believe you have that decompression is good enough, all you need to do is, I will prefer going anterior, and maybe 3-level ACDF with a plate if need be. That is where, at least, I think, if you do that, you should be able to get a good reversal of lordosis. But going posterior is also an option, but in my hand it's a difficult option, so I like to, maybe anterior approach works better with me in this case.
Right. So for me, actually, I had no option. Because she's a very poor lady. She couldn't afford a posterior construct. So I had only the option of ACDF, and I had just one plate. So this is what I did. So I had to use a fibular graft because I didn't have the appropriate size cages at C2-3. So and also the plate was not of enough length to cover all the cages. So actually, this is a 5-level ACDF I did. So this is the pre-op and this is the post-op. So this is the maximum I could achieve with what was available. I know it's not great.
It is good enough. It's good enough. You have taken away the reversal of lordosis, and I'm pretty sure she will do fine, because the whole idea is to get it back. If you make her kyphotic, she will be miserable, especially the cervical spine. As we give a lot of importance to lumbar lordosis, but I think it's equally important to have a good cervical lordosis as well.
Yeah, so this is the pre-op and this is the post-op. She improved considerably. But don't you think that this patient needs posterior fixation as well? Do you think anterior fixation is enough for this case?
Yeah. So you can go do posterior. But I think best what I will do if I have to do it, maybe do a first stage anterior, see how she goes about it. If needed, keep the posterior as an option, as a backup. And if you feel for whatever reason you feel that it's not working, you go and do posterior, because posterior is not only, it will be a lot of it won't be easy, because if you want to do it, maybe you need to do OC from occiput to C5, C6. So is likely to lose a lot of hand movement. It is going to be a lot of challenge, because you will have to go through scars and everything. So I always believe keep it simple as possible, but keep your backups open. There's always option. If you need to go, you go another day. There's always another day in these cases.
Right. Thank you, Ayush. And this is the last case I wanted to get your opinion. Again, a 47 years old female. Now she presented with both features of both cervical myelopathy, severe myelopathy, and also severe lumbar radiculopathy as well. So this is a MRI. So you could see uh, there is myelomalacia at this level with cord compression both anterior and posteriorly. And again here,
Awesome.
you can see the compression as well, and this is the cervical spine, the axial cuts. So 3, 4, 4, 5, 5, 6, 6, 7, and this is her CT. You can see a bit of OPLL as well here. So you can see it's mainly at the posterior margin of the vertebral bodies. Not much, but considerable amount. And again, this is the thoracic spine. You could see the compression is here as well. So she got both cervical compression, thoracic compression. So again, there is calcifications here as well. You could see as your case before. And this is the lumbar spine. So she got severe lumbar radiculopathy as well. So in a case like this, what did you do first?
So in terms of priority, the cervical has the maximum priority. That is where what I believe in. If you have to choose, if she is symptomatic for all the three problems, now it becomes very difficult sometimes. But whatever it takes, you try to use whatever clinical tools you have in your hand and try to differentiate where is the problem coming from. But if you believe that all the three, the cervical, the thoracic, and lumbar, all the three are symptomatic, then in terms of priority, my cervical will take the priority 1, the thoracic will be priority 2, and the lumbar is priority 3. Now it totally depends upon whatever team or setup you're working in. If you're working in a good setup which can, you have a good team, maybe you can tackle at least the cervical and the thoracic in one go. If because both the dorsal or the thoracic is really bad, and so of course the cervical you have to tackle, and maybe lumbar can wait for some time. Or if you think you are like single surgeon who you cannot do, and you think it will take you very long, and the patient current condition doesn't allow you to do all 2 or 3 of the surgery together, I think I'll follow first the cervical, let her heal, let her recover, then do the dorsal. Most of the time, when you do these two, the lumbar you can wait, and it's not emergency. I'll do it maybe after 3 or 6 months, if only if she really insists I have to do the lumbar surgery. That is where I am.
Yeah. So will you go anteriorly or posteriorly for this patient, cervical?
So as I told you, if you have to do single stage dorsal and lumbar, or dorsal and cervical, posterior is the option, because you can do both together.
Same
So
time.
so I will prefer the posterior approach.
Right. So exactly the same thought process. So I wanted to do the cervical and the thoracic at the same time, but she's a healthcare assistant in my ward, so I didn't want to take a chance. So what I did, this is what I did. This was done yesterday. I did a 4-level ACDF for the patient, and so we'll give her some time and see how the symptoms are, whether it resolves or not, and then depending on that, we'll go for the thoracic and the lumbar at the same time, because I did this anterior. So the next go, I do the thoracic and the lumbar one at the same time on the posterior approach. So this is what we did. All right, so she's fine, absolutely fine.
So I think it's a good idea to, you do one thing, let the body recover, let the healing process happen, let the symptom resolve. And, you'll surprise. There are a lot of time when we have seen is what happening is once you have done the cervical and the lumbar simply, they don't care about it. They are so happy with what you have done. Even it looks very bad on MRI, the lumbar is not a problem. That is where it is.
Oh, yes. Thank you very much. I want to take a chance, especially with the healthcare assistant working in my ward.
Yeah, I
So,
understand. I will do the same thing because if you know a patient and he sees work in your ward, it's better to take it safe one step at a time.
yes, right. Thank you very much. So that's it. So that's it for today, and thank you very much, Dr. Sharma, and thank you, John, for giving us the opportunity. So we can continue sharing the cases for the complications in cervical spine as well on a different day. So, and also the cervical and the thoracic spine. So we look forward to that. So
Okay, very good. That's you guys are interacting well. I'm sure people watching and that are going to watch in the future will get something out of this lively interaction. Dr. Sharma, could you just briefly go through your website? It's a very good website. I'd like to have you show the audience.
Yeah. So should I just go through?
Yeah,
So
just tell us about your website. It's a good source of information, I think,
one second. I'll just
for your area of neurosurgery that you kind
yeah.
of specialize on.
So oh shit. Okay. So basically, could you open it up on your this page? Then it will be very easy for me to share. So basically, could you just go to the Google www.laserspine.in for whatever reason I'm unable to open it right now.
Okay, I can share it if you want.
So basically, if you look at the website, it's very simple. It's called www.laserspine.in, and if I let the John share it with you.
Yeah, I'm going
So
to get to it right now because I put that on the description of your bio.
Yeah.
Yeah,
So
that's one thing I noticed. Okay.
Basically, if you go to it, you have a lot of information on it. We have you'll have get small links where it takes you to our Facebook web page. It even takes you to our the YouTube channel, and all these are totally integrated together. So it allows you to if you want to see anything like you want to see a video and or like for example most of
laserspine.in, right?
yeah www.laserspine.in. Yeah.
Okay. Let me go to that. Just give me a second.
Yeah, sure.
Okay, yeah, it's quite a good website. Let me just get it up here. Okay, there we go. Take us through, please.
Yeah. So if you can see the home page, can you go in, go down, please?
Okay.
Yeah. So it gives all the information about what we are, what we do. These are my co-directors, and you can go down. Yeah. So yeah, please go down. Yeah. So it is small video for patient education. As you go, you can subscribe to our website. Please go down slightly, and as you go in, yeah, more down. Yeah, please. You have all this link. You have a link to your Facebook. You can see an Instagram link. You can have my LinkedIn link. You can have YouTube link. Just click on the YouTube, just for the viewers.
Click on the YouTube, sure.
Yeah. Just go through it. The moment you
quite
click,
quite an active channel. Okay, go ahead.
Yeah, you go through this. Go to my YouTube channel. It has more than 76 videos. You have like one of the olive surgery live. You have a lot of what we do. You can see if you're interested in spine surgery. A lot of my field of interest is minimally invasive spine surgery and cervical myelopathy. You'll see a few talks which I have given, some of the things which we do, and it's if you are interested, you just go. You can just subscribe to that website, and I think that is the whole idea of having that.
Yeah, that's probably one of the better websites you're going to see a YouTube section on endoscopy, correct?
Yeah. Exactly. Yes. So thanks,
It's
John.
good, a lot of information.
Yeah. So we tried and like we did a different surgery. We tried to sort of put whatever we do. Even if you see the Facebook page already has a link for this talk. So someone is interested, he just goes. So whatever we do, whether small or big we do, we sort of try to keep people updated. That is where
you guys make a nice team. Very good. Okay, thank you very much, Suraj, and thank you, excuse me, Ayush. Thank you both, and we'll see you in 2 weeks, correct? We're going to go over the cervical spine, complications of cervical spine, correct, Suraj?
Yeah.
Yes.
We should look into that.
Okay, great. We'll see you in a couple of weeks.
Bye. Good night.
Thank you.